Hello and good morning. Thank you for joining the National Academy of Medicine Culture of Health Program, Advancing Health Equity, Science, Practice, and Outcomes Listening Workshop. I see a number of folks that are still coming on the line, so we're going to give about 1 more minute before we begin the formal program. But thank you to those who are on the line and are joining us. Okay, I'm going to go ahead and get us started again. So good morning and thank you again for joining the National Academy of Medicine Culture of Health Programs, Advancing Health Equity, Science, Practice, and Outcomes Listening Workshop. My name is Ivory Clark and I am the director of the program. We have an informative and engaging lineup of speakers joining us today, and I'm delighted to have each of you joining us as well. Before we get started, I want to point out a few housekeeping items. One is that our meeting today is being hosted over Zoom and it is being recorded. Next slide, please. The chat feature has been disabled, but if you have any technical issues, please use the Q&A function and we will work with you to troubleshoot. So on your screen, you'll see an image of what it should look like on your Zoom platform. So if you're having any technical difficulties, please do reach out to us through the Q&A box. The Q&A box will be open for the duration of the webinar, and we also invite you to ask questions throughout each of the sessions in the Q&A box. We'll have an audience Q&A at the end of the meeting from 2:15 to 3:15. Next slide, please. Before diving into the webinar, I would like to provide a brief overview of the Culture of Health program and the purpose of our listening workshop today. The Culture of Health program launched in June of 2015 as a collaborative partnership between the Robert Wood Johnson Foundation and the National Academy of Medicine to operationalize the Foundation's vision for building a culture of health that is grounded in the evidence base, multi-sectoral in its collaboration, and engages the range of stakeholders necessary to have real and meaningful change happen. The mission of the program is to identify strategies to create and sustain conditions that support equitable good health for everyone living in the United States. During this multi-year collaborative effort, we've centered our work around 4 primary goals, and the program has achieved a number of accomplishments using multiple modalities within those goals. Our 4 goals are to lead by building a solid knowledge base, to engage, strengthening capacity at the community level, to sustain this work by transforming culture and creating a shared value system, and finally to translate, bridging science to action, ensuring that those who want and need the important information that becomes available through the program is truly accessible. We've completed 4 consensus studies under the program, which review the available evidence on advancing health equity across the local to federal spectrum and through the life course. We undertook traditional and novel activities that communicated the science to broad audiences. We've facilitated the development of community-driven health equity action plans to advance and demonstrate application of report recommendations, and we fostered cross-sector multidisciplinary conversations, collaboration, and action in support of the recommendations from our reports. These efforts were only the beginning of providing a reliable evidence base, building a network of stakeholders, and developing and disseminating resources to further advance a culture of health. I'd like to thank and acknowledge that we have an 18-member advisory committee that provides strategic guidance to ensure the program meets its intended goals. Our members represent diverse areas of practice and expertise, including research, policy, practice, and advocacy, and their disciplines span across health, education, economics, technology, environmental science, urban planning, finance, community organizing, as well as local and federal policy. The program aims to create a shared understanding that health is more than disease, treatment, and what occurs within the clinical walls. A culture of health exists when people recognize that health is linked to access to care, as well as the environments in which we live, learn, work, play, worship, and age. Our first report under the program, Communities and Action Pathways to Health Equity, identified 9 social determinants of health, and they're available on your screen now. And these determinants include education, employment, housing, transportation, the social environment, the physical environment, public safety, income and wealth, and health systems and services. The report acknowledged that personal responsibility is a factor in one's health, but we must also understand that the choices an individual makes are dependent on the opportunities that are available to them. This leads us to an understanding of health equity. Health equity means that everyone has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstances. In short, that everyone has a fair shot at living the healthiest life possible. Next slide, please. I'll share just a few of the lessons learned from the first 5 years of our work together. These lessons included that health equity is crucial because it's fundamental to living a good life and building a vibrant society. Enacting change requires a broad group of stakeholders, including scientists, policy professionals, healthcare services, educators, folks from the transportation sector, the business sector, artists, etc., to come together to innovate and strategize a way forward. And empowering communities must be at the heart of our efforts, and stakeholders should address the needs that communities want to fulfill, not necessarily what stakeholders believe communities should have. As we continue to explore opportunities to further advance health equity and build a culture of health across the nation, I want to emphasize for today's conversation this second bullet point. Over the last several months and throughout the end of the year, the Culture of Health program is engaging with key stakeholder groups to form a deeper understanding of the priorities and perspectives of these groups in order to uncover common ground that will form bridges and collaboration necessary to advance health equity. We're holding a series of listening workshops to hear from 3 key stakeholder groups who have an impact on the policies and systems that can reduce health disparities, and to understand what the most pressing scientific questions are for the field, where priorities are heading, what challenges are being faced and likely to come in the future, so that the Culture of Health program can support these stakeholders. The groups that we are inviting to engage in these next couple of meetings include researchers and practitioners, decision makers, as well as organizations that are accountable to and elevate the voice of communities. This past summer in June, we hosted a meeting with a number of leading experts and scholars across multiple areas of research and application to explore priority areas and strategies for achieving the structural changes necessary for advancing health equity. Next slide, please. The purpose of today's workshop is to explore the gaps, barriers, challenges, priorities, and opportunities for decision makers in the public and private sectors to continue to advance health equity. We will examine the historical perspective and current state of affairs for decision makers advancing health equity through policy, practice, and systems. We will identify where there are evidence or understanding gaps for decision makers to take action on health equity, what barriers impede them in their efforts to advance health equity, and the anticipated implications of COVID-19 and an increased focus on structural racism. We will discuss where attention should be focused to aid decision makers in action to advance health equity in a post-COVID world, and we will identify opportunities to engage other partners and sectors to advance health equity. Before I turn to the National Academy of Medicine's Executive Director, Dr. Michael Mcginnis, to offer additional remarks, I would like to acknowledge the hard work of the Planning Committee, comprised of our Culture of Health Program advisors, Angela Diaz, Patrick DeLeon, Otho Kerr, Tipi Ziwin-Toman, and Martine Sepulveda. I would also like to acknowledge and thank my colleagues on the staff here at the National Academy of Medicine, who have been instrumental in the development and execution of this program. A special thank you to Julie Tarrant, Stephen Shakura, and Ayadola Aniche. Thank you again for joining us, and I'll now turn to Dr. Michael Mcginnis, who is the Executive Director of the National Academy of Medicine, to offer additional remarks. Michael?
Thank you very much, Ivory, and really a very warm thanks and welcome to each of you who has joined us this morning. I'd like to start off, I think, by emphasizing the importance of today's meeting on three dimensions. First, its focus on the culture of health. A culture of health clearly is a culture in which everyone has the awareness and the support to achieve their full health potential, as Ivory mentioned. And it grows out of a national effort that the Robert Wood Johnson Foundation has developed. And we are so pleased to partner with RWJF in that respect, and especially given the fact that there is no culture of health without a culture of health for everyone. The notion of health equity is front and center in our vision, our collective vision, and the vision really of everyone who is joining us today. So the notion of ensuring that we are doing everything we can as a society to foster the development of a culture of health is absolutely critical. It is the most critical issue for us in this nation, as we have seen underscored during the period of the COVID-19 pandemic. The most dramatic challenge and the most dramatic failure in many ways related that we've seen in the course of this pandemic has been our ability as a nation and as a society to protect everyone on equal grounds and equal footing from the ravages of the pandemic. So as a society, we are dealing today with simply the most important issue that's confronting society. The second dimension I want to emphasize in terms of the importance of our conversations is for the National Academy of Medicine. We are, as you see with this insignia, which is above my left shoulder, entering our 50th year. And in fact, we start this weekend the celebration of our 50th anniversary. So this is the meeting that is carrying us into that anniversary celebration. And our role is to serve fundamentally as advisor to the nation on the evidence that indicates the most important directions for us. And that means that we have a important and unparalleled opportunity and obligation to ensure that the science base and the evidence base that is available is as strong as it can possibly be and is growing to address the most important problem that the nation faces around the challenges of health inequities. We have spent the last 5 years in our Culture of Health program marshaling the elements of the science base, and we will spend the next 5 years of our partnership with the Robert Wood Johnson Foundation growing and refining that science base and shaping it in a fashion that is not only easily accessible, but is made available in a fashion that those of you who are decision makers in the nation can carry it forward in as efficient and effective a manner as possible. So for us, this meeting is vitally important because we're going to hear from you what elements of the science base are most important for you as you undertake your challenge, implement your missions to reduce and eliminate health inequities throughout the nation. And again, we thank you very much for coming to us with the information that and the insights that you will be providing. I should make one other comment just to underscore the importance of this meeting for us as the National Academy of Medicine, and that is that in our recent work to revise the mission of the National Academy of Medicine, we very specifically inserted the focus on health equity. Our focus is to ensure that the best available science and evidence is available to meet our vision, which is to improve health for all by advancing science, accelerating health equity, and ensuring the best care and health prospects for all Americans. The third issue that I want to emphasize related to the importance of this meeting, I've already given some hint of, and that is you folks. The presence of our primary vehicles for ensuring that the science base is applied in the most effective manner possibly. And we have an extraordinary group of organizations that are represented here: federal, national, state, local, national organizations, to help us in this conversation, both as speakers and in the audience. We have, for example, representatives from the Indian Health Service, NIH, CDC, CMS, HRSA, the wide variety of federal agencies that are charged with implementing federal policies that can eliminate health inequities. And thanks to each of you who are from those agencies who've joined us here today. We have here NGA's Timothy Blute. We have the Conference of Mayors, Tom Cochran. We have the Human Services Association's Matt Lyons. We have the National Collaborative for Health Equity's Brian Smedley. The Association of Latino Elective Officials, Arturo Vargas. We have, in addition, the League of Cities, Irvin Bishop, and Living Cities, Julie Bosland. The Democracy Collaboratives, Dana Brown, Kaiser Permanentes, Cecilia Echeverria. AAMC, the American Medical Colleges Association, Karen Fisher, Families USA, Amber Hewitt, and also Frederick Isasi, who's going to be speaking with us. We have representatives from the Chamber of Commerce, from the Child Welfare League, and obviously I can't go through them all, but you folks represent both the most important means of our understanding what elements of the science-based are most important and meaningful to you, and also the primary vehicle for reaching our ultimate targets among the American people, and in particular, those among the American people who are most at risk. So I want to underscore my thanks clearly to Ivory and Stephen and Julie, who've helped put this together and who are leading our efforts in partnership with RWJF, but especially thanks to each of you for sharing your time, your leadership, and your energy, and we look forward to that partnership. Thank you, Arby. Back to you.
Thank you, Michael, for those warm words of welcome. And I'll ask Julie to pull up our remaining slides. I want to just, next slide, please. I want to just remind folks again about the Q&A box. Throughout the meeting, we will be curating your questions as they come in, so please feel free to ask questions during any of the presentations, and we will respond to as many as possible at the conclusion of the meeting from 2:15 to 3:15. If you have any technical difficulties, please also use the Q&A box for sending those requests our way. In terms of logistics for each of the session, I will be reading a brief bio for each of our speakers at the start of the session. However, I would like to note that full bios are available in the digital briefing materials that were sent to you in advance of the meeting. Next slide, please. To facilitate a bit more of an interactive meeting, we will be using Poll Everywhere throughout the meeting today. Poll Everywhere is a real-time polling tool in which we'll ask questions and invite you to provide your responses. Answers will be displayed in real time on your screen. To participate in the polls, you will need to either use your cell phone or a computer to submit your responses. To participate by computer, please open the web page you see on your screen, and that's pollev.com/NAMCOHP752. You can also participate by phone by simply texting NAMCOHP752 to 22333. You only have to text the NAM indicator to 2233 one time and not for each question. To practice using poll everywhere, I'm going to ask that Julie open our first poll. For this poll, you do have to respond using your computer. Each of the other polls will be available on either your computer or your cell phone. So I ask at this time for you to navigate to the poll EV/NAM COHP752 website, as you can see at the top of your screen, and using the map, indicate where you are joining us from. We'll leave this poll open for the next minute and allow the locations to populate on our screens. I see some questions asking us to include the chat and the link in the chat box and the Q&A box, so we're doing that now. Just about another 30 seconds. Excellent, thank you. We will be sure to include the links and the poll everywhere texting within the chat for our future polls. Thank you so much for completing this first poll. It looks like we've got quite a wide geographical range of participants today. So thank you all again for joining us. I'll now transition us into the remainder of the meeting. Next slide, please. Our first session is entitled Drivers of Inequities, Implications from the Past for Moving Forward, Where We Are Now and Why. We are joined by Dr. Colin Gordon and Dr. Kara Odom Walker. Dr. Gordon is a professor of 20th century U.S. history, American public policy, American political economy, and American urban history at the University of Iowa. He writes on the history of American public policy and political economy and is the author of a number of notable titles, including Citizen Brown, Race, Democracy, and Inequality in the St. Louis Suburbs, Growing Apart, A Political History of American Inequality, Mapping Decline, St. Louis and the Fate of the American City, Dead on Arrival, The Politics of Health in 20th Century America, and New Deals, Business, Labor, and Politics, 1920 to 1935. His digital projects include online companions to Citizen Brown and Mapping Decline. He is a senior research consultant at the Iowa Policy Project, for which he has written or co-written reports on health coverage, economic development, and wages and working conditions. Dr. Gordon received his PhD from the University of Wisconsin-Madison. Dr. Kara Odom Walker is the Senior Vice President and Chief Population Health Officer for Nemours Children's Health System. At Nemours, Dr. Walker leads the Nemours National Office, Advocacy, and Public Policy, as well as all aspects of population health strategy, research, innovation, and implementation. Prior to this role, she was the Secretary of the Delaware Department of Health and Services and served in Governor Carney's first elected term from February 2017 through 2020. As secretary, she led the principal agency charged with keeping Delawareans healthy, ensuring they get the health care they need in a fast-changing world, and providing children, families, and seniors with essential social services, including food benefits, disability-related services, and mental health and addiction treatment. She's a board-certified family physician and is a fellow of the American Academy of Family Physicians. Dr. Walker completed her family medicine residency at the University of California, San Francisco, graduated with a Master's of Public Health from Johns Hopkins School of Public Health, and a Master's of Health Services Research from the University of California, Los Angeles School of Public Health. She is also a recent member of the National Academy of elected a recent member of the National Academy of Medicine. Dr. Gordon and Dr. Walker, thank you for joining us, and I'll turn to you now, Dr. Gordon.
Good morning. You can see my slide okay?
Yes, we can.
Okay, good. It's an honor to be here. I just have a few sort of opening comments on historical perspectives on the problem of health equity, which I see sort of flowing in two distinct channels. First of all are those relating to social policy and access to healthcare itself. And the second relating to local demographics, local segregation, and the local culture of health, or the social determinants of health. The important starting point here, I think, is to recognize the neglect of healthcare in the formative years of the American welfare state. That is, in crafting the Social Security Act in the 1930s, we pretty directly rejected both any universal programs like health coverage, but also any universal standards, famously striking the decency and health standard that was attached to the original draft of the Act. And instead, we settled on a system of largely contributory social insurance programs built around pretty sweeping occupational exemptions, at the time leaving out all domestic and agricultural workers, which meant that at passage, the Social Security titles covered about 2/3 of white workers, but fewer than half of African American workers. This also drew, in a sense, a hard line between deserving citizens, those who earned social protection through participation in the labor market, and undeserving citizens who made much more meager claims on general revenues. As Charles Houston of the NAACP noted during the hearings on the Social Security Act, this was a sieve. The holes were just big enough for the majority of Negroes to fall through. And over the course of the next half century, 3/4 of a century, this yielded two important consequences. The first of these legacies was a reliance that flowed from the fascination with social insurance, a reliance on job-based provision, particularly for health and pension coverage. Now, this posed something of a dilemma, because job-based provision actually widens inequalities rather than narrowing them. That is, good health coverage goes with good jobs. And as you can see from the graphic on the screen, the share of workers with job-based coverage rises pretty dramatically, both with income and with educational attainment. In a sense, private job-based provision simply multiplied the opportunities for discrimination, membership in a labor union, hiring gate discrimination, and occupational segregation among them. And it also meant that it entrenched disparities based on race and ethnicity. That job-based coverage flowed from patterns of occupational segregation and job-based discrimination, so that regardless of the sort of pattern of job-based coverage or the level, the gap between white workers and black workers, between white workers and Hispanic workers, remained pretty dramatic. And this is true even as the ACA brought down uninsurance rates overall, the gap between ascriptive groups remained pretty powerful. And of course, infamously, our system of job-based provision is, as one observer put it, an umbrella that melts in the rain. It disappears when we need it the most. Something was underscored in the dramatic job losses that we saw with the COVID recession. Best estimates are that over 12 million Americans lost job-based coverage between March and August of this year. And of course, the options, Medicaid, ACA, private purchase, are very uneven, both regionally and across income groups. The second important legacy of this sort of origin story of American social policy is a pattern of federalism and what Jamila Michener has called fragmented democracy, that is regionally uneven coverage, which leaves wide discretion to states as to who is covered and to what degree they're covered under public programs. This was compounded, of course, by the fragmentation of our public system of coverage, which was crafted really essentially to mop up after job-based coverage, to sort of pick up those who had aged out of the labor market in Medicare, those who are on the margins of the labor market in Medicaid, those whose employers did not provide coverage, which is the focus of the ACA, and then of course a series of categorical public programs, the VA, the Indian Health Service, and such. But what this meant is that we yielded a lot of access, generosity, and inclusion to states who had an uneven commitment to social policy and to the citizens within their borders. And so we see a stark regional cast of what I would characterize as sort of old conservatives, the Deep South, and the new conservatives in the Mountain West, providing much less generous coverage. Here, mapping the share of the poor receiving Medicaid, and here, of course, mapping the expansion of Medicaid, or the failure to expand Medicaid under the Affordable Care Act. And of course, the consequences are clear, both in rates of uninsurance and in patterns of risk in the wake of COVID. The second important element that I want to put my finger on, which I think is extremely important, are patterns of local segregation. And I'll draw here on my research on St. Louis just to illustrate this point. The border and northern cities in the United States particularly built up an elaborate architecture of segregation in response to the Great Migration. St. Louis had a racial zoning ordinance in 1916. This was thrown out by the Supreme Court, but replaced by a set of restrictions imposed by local realtors, which was buttressed by race restrictive deed covenants, which infamously defined African-American occupancy as a nuisance. Racial covenants were declared unenforceable by the Supreme Court in 1947, but they lived on in various forms in the private development of property, particularly during the suburban boom, the 1940s and 1950s, and they're referred to explicitly in the federal redlining maps of the 1930s and 1940s, which carried forward the basic spirit of those restrictions. And of course, they became embedded in patterns of municipal zoning, which, as this map shows, became more and more exclusive as you moved out from the urban core. So all of the commercial, industrial, and multifamily use is in the central city, and increasingly exclusive single family and exclusively single family use as we move out into the suburbs. What this yields is a particularly stark pattern of segregation in cities like St. Louis, which has a deep and lasting impact on local patterns of health equity. It yields, among other things, dramatically uneven access to local public goods, particularly those paid with property taxes like schools, uneven access to private goods, and so this yields food deserts, spatial mismatches in employment, It yields uneven access to health facilities themselves. Across this area, we see the closure in St. Louis and elsewhere of urban hospitals being largely displaced by suburban health campuses. We see patterns of environmental racism and risk of local exposure and yawning resource gaps, especially racial wealth gap, that is a direct legacy of this long century of housing discrimination and segregation. And those racial patterns map very neatly then onto what we see in patterns of COVID risk, here mapped for St. Louis, and of course in the outcomes, in the dramatic racial gap in which African Americans, in terms of both cases and deaths, are exposed to COVID at more than twice the rate of white non-Hispanic Americans. So I think in many respects, this history is a story that's driven by what I would characterize as the three phases of segregation in the history of American social policy. That is, first of all, we have occupational segregation, in which we allow the labor market to sort access to job-based coverage and to sort citizens into those deserving and undeserving camps. We have patterns of policy segregation in which we've yielded to states substantial discretion in terms of establishing the inclusiveness and the generosity of their basic social programs, something that is now deeply embedded in our core public health program, Medicaid. And we have these powerful local patterns of segregation, which fundamentally sort access to both public goods and private goods and to economic opportunities. And that yields overall, as I suggest, a sort of deep, a long historical shadow that casts itself on our current moment and on the stark racial disparities that we see in the current pandemic. And I'll leave it there and pass it over to Kara Walker.
Thank you, Dr. Gordon. Dr. Walker, we'll turn to you now.
Thank you so much for this opportunity. Making sure my slides are showing.
They are.
Great, thank you. So it's a pleasure to talk with everyone today. As I reflect on the experiences that I had going through COVID as Secretary of Health and now transitioning into a health system that's trying to tackle these issues, I truly believe we are at this moment of inflection that presents a unique opportunity for us to think about policy decisions, how systems interact, and how practice can change to equitably improve health and well-being. And as Dr. Gordon suggested, these crises of the COVID-19 pandemic, social injustice, and our contentious political discourse has certainly highlighted the impact of systemic racism in America. But I do believe we can make strategic investments and look forward to the discussion today. My role now is to think about how Nemours as a health system creates a healthier generation. And my position is that it will take time, it will certainly take money, and it will take collective engagement. But we can get there. So I think one of the moments that we all have reflected on many times over is that George Floyd certainly reminded us how many young people start out in life holding the promise of tomorrow. But even as his brother has stated, he was born with two strikes against him, being born Black and being born poor. But he worked hard. He graduated from high school, was the co-captain of his football team. He even took his team to the Texas State Championships, went to college, but unfortunately, as we know, those factors that create positive outcomes in education lead to challenges. And unfortunately, he dropped out and he died too soon. We haven't figured out how to ensure equal access to resources, mental health, what he particularly needed to navigate the criminal justice system and barriers to jobs and social networks and housing. But they certainly brought these issues back to the forefront in our national dialogue. And I believe that we all want to figure out how to create healthier people, healthier communities, and a healthy economy. What we also know is in healthcare, we are spending a lot in terms of our healthcare dollars, but we are not necessarily healthier. And 18% of our GDP is opposite of what we want to buy. We have persistent health inequities that boil down to often just simple income and opportunity gaps. We have more to do. Oh no, I think I made my slides disappear. Can you see them?
No, we do see a great background though.
A dream, I know. Can you see it again?
Yes, no, we can't.
Great. Apologies. So sadly, we know that these investments are directed towards what we want, healthier healthcare programs. They aren't necessarily paying for healthier people, health equity, and we are not necessarily focused on those who need the most resources to prevent long-term costs. We also have more to do around investing. And my key recommendation for this dialogue is that we have to figure out how to align the dollars, incentivize equities, and we need to start somewhere. And I think in terms of my prior view of the world where policymakers are trying to figure out where to bring people together, where to find consensus, that we could focus on the health of children, specifically including low income and children of color. We know just one example around the Affordable Care Act, and as we saw in the prior slides around Medicaid, we know that there are many healthcare options available to uninsured adults and children. And this is certainly includes a group where Blacks and Hispanics are overrepresented. But unfortunately, those health disparities, those racial and ethnic disparities still exist among children and among minorities. And there were many decisions along the way among policymakers that eliminated this comprehensive health reform in favor of a bill that would focus on reforming health care and coverage. So that just left out a lot of the social determinants work that had been advocated for. And it wasn't a popular conversation to necessarily talk and focus on race and equity. We also know that of the $3.5 trillion that we spend in healthcare, it is a significant amount of money, and 8% of the economy is directed towards healthcare. By 2028, we estimate that these costs are going to continue to grow to 2.9 trillion or 9.7% of the economy. Yet they're not still focused on health or what we really need for equity. The other challenge that we have in an ongoing way is that we have more to do around spending in other areas. And the challenge with the imbalance of spending so much in health is that we're pushing out spending in other areas, particularly in social costs and programs that actually will help create greater equity. This is certainly the case at the federal and state level, and many of the conversations I had with executives were around how do we make this come together around needs to raise those who need it most, but also recognize that there are some costs and inflationary changes that we can't control. We have reduced spending overall in our country in the brown shaded region because of this increase that we can see very clearly in the middle section of this graph and healthcare programs. And that includes Medicare, Medicaid, CHIP for children, as well as what we do to subsidize spending in health insurance and try to stabilize premiums purchased by individuals and small employers. We also know that when we look across other developed nations, our respective public social spending as a share of GDP, as shown in this graph, is relatively low. And that can include things like what we do to support people for health and old age, for disabilities benefits, for family support programs, unemployment and housing. It'll be very interesting to see this graph again after COVID, but certainly COVID-19 has cast a bright light on the impacts of these structural inequities, and communities of color, including Black, Latinx, Native American populations, are facing the highest infections and worst outcomes because they are often in service fields that don't have the same access to those informal and formal supports like paid time off, childcare, and other factors that would reduce the risk of infection. And these are the social determinants of health that we know are so critically important. What I would also say is that we know that healthcare is spending is low, and we have more to do. We often talk about where we were in terms of spending and creating a paradigm around race that has evolved. But unfortunately, it is this conservative framing that we should be colorblind and therefore not talk about race. And because Americans often have historically valued individualism and pulling yourself up by your bootstraps, it is difficult to talk about racism and race. It's difficult to make these arguments in the political space that address structural inequities because of the challenges. And even in this famous quote by Martin Luther King, where I want to live in a society judged not by the color of my skin, but by the content of his character, we often don't talk about the second part of his quote, where he also talked about economic opportunity and the importance of making sure that you can also afford those abilities. We need to put money into these economic and opportunity equalities, and combining this historical perspective with the lessons of COVID-19, I think we can get to a place where we're thinking more heavily about how inequality in terms of monetary wealth and health outcomes and political influence will allow us to focus in on future opportunities. What we also know is that when we look at the curve in what is in our healthcare system, there is clearly money in the system. We can reorient these funds towards equity and health. Let's take this deviation from the curve and right size it towards equity issues and towards how we're taking on these very challenging times and very important lessons that we're learning. Even before the pandemic, we knew that the social costs were often low, and as funding in healthcare has increased, we've seen the social spending shrink even further, as you can see by these declines in comparison to what we're spending in health. So I believe that this is a call and a request for us to figure out how to put more dollars in. And I know part of our listening today is to think about how we reorient some of these investments. We know that there are many programs that have been called out by the National Academy around reducing child poverty, for example, where we know that 9.6 million children in the US are still living in families below the poverty line. We know that investing an additional $1 trillion that could be used to eliminate health disparities. It could, in fact, look at existing policies and programs that could reduce child poverty in the United States by half over a 10-year period. This would, in essence, get us much further. We also have several barriers that need to be addressed and figure out where we go from here. I think the first step is getting our voices out there through voting, having greater diversity in political leadership, as well as collective efforts around enhancing the community's voice. We can also figure out how to commit to addressing structural inequity through job training, HR policies, a health and all policies review and approach in corporate leadership. And finally, we need to figure out how to commit to enhanced attention towards criminal justice reform and a conservative legal interpretation of race-based policies that give greater view and insight to where we go. So some of our challenges are around the interpretation of these colorblind approaches that don't necessarily bring up those who most need it. It has led to challenges, and many authors out there have spoken to it much more eloquently than I ever could imagine. But I do think our words unfortunately create a gut reaction, and we have to be careful of what words we use in the policy space. How we bring people together is critically important. Reparations is not equal to the thoughts of affirmative action, which is not equal to the thoughts of equitable structural justice. We have to find words and funding that allow us to bring up those who are most likely to have left behind, but also focus in on those funding opportunities, those policies, and that structural reform. Forgive me, I am an engineer by background and training. I think you can mathematically solve for many of these things, but this equation shows the reverberations can carry forward. It's a mathematical formula that is relevant in music, but it really says with the current moment that we're at with COVID-19 and racial awareness, let's carry these reverberations forward into funding, into decisions, and into policies of the future. So unfortunately, we do need to move beyond this idea that color blindness will get us far. We actually need race conscious and racially informed approaches. We need to figure out how to pursue the concepts that have been raised by many who are focused on how we get beyond the dialogue that we're in now. My recommendations, and I look forward to those of the group today, are to focus in with policymakers in 4 key areas. First is thinking about equal access to jobs and social mobility with data-driven, evidence-based approaches. We can start there. Second, we can engage the political process. Everyone needs to ensure that money is not the driver of outcomes in elections, and that corporate influence does not leave behind these goals, and that there is accountability in the system. Third, we also want to think about how we pull together in the healthcare space and beyond around livable wage, around income that doesn't necessarily predict alone with greater accuracy around who graduates from higher learning, who graduates from high school, who achieves 3rd grade reading levels, or who is ready even for kindergarten. And then finally, we need to pull in this accountability and concept of corporate responsibility into the framing to ensure that we have wage equity, board participation, and full community engagement with this eye towards racial equity. I think we can get there. And we can even do so in a way that pulls along our policy makers and levers, that isn't a complete reimagination of the system that exists. We can do this through policy levers where COVID can shed a light on where we need to invest. And even for just child poverty alone, we can think about earned income tax credit, SNAP, Social Security benefits, WIC, and housing, and even how we think about our social system. So as I wrap up, I know that our leaders want to hear from everyone, and we need to use the right words and choose our words wisely. We can also do so by putting data into the hands of communities, our organizations, and the political process. We can start with the children, who often aren't as much of a political football, and think about how to invest. We can think about how to do so in education, where we're thinking about educational as a risk factor, that often we're having less than a high school education is linked to higher death rates, more so than stroke, Alzheimer's, suicide, or other risks. We can think about food insecurity, which is a major issue right now during COVID, to specifically tie to health outcomes for those who are facing food insecurity, and even just considering adding to SNAP benefits that actually produces better educational outcomes as well. We also know that those supports, income supports, social supports, behavioral health supports, can help families become stronger and overcome the impacts that we know are rising around adverse childhood experiences right now. And this is just one factor, one social determinant where untreated adverse childhood experience scores in children predicts a 20-year decrease in life expectancy. There are many opportunities for us to continue forward. We also know that, unfortunately, one more ahead, that we have more to do around making our healthcare system the best in the world. And some of that is outside the walls, and some of that is around addressing the intersections between criminal justice reform and healthcare, and what happens in our emergency departments, what happens around access to jobs, even within the walls of the healthcare system, how we support those who are navigating homelessness and housing. And all of these factors could have truly impacted the life of George Floyd. So we know at Nemours, every child has an opportunity for the future. We are working internally and with partners to think about the racial equity lens. But I know all of you listening today are also critically thinking about these issues and trying to figure out how to make sure everyone has a chance to be healthier. This is just one way, and I think about this, how we use the right words and how we create a politically palatable message and attainable financial opportunities. But in some ways, starting with children is a space that is potentially pilot. It's a precursor to a healthier generation. They are only 7% of the total health spend in healthcare, but they are a big lever that can exert a tremendous impact on societal outcomes. So what if we just started there and got to a place where we could successfully engage political leaders and our legal system in a new investment strategy in equity? What if we could invest in poverty elimination that is informed by these same structural inequities, race and class? And what if we could change the dialogue about poverty beyond just individualism and blame and shame, but we instead use the COVID-19 pandemic to reinforce our need to realize that there is potential, that we can reorient and we can reimagine to invest in a healthier generation from all of this. I think to get there, it truly takes many voices and a collective network opportunity. As Winston Churchill said, never let a good crisis go to waste. And for me personally, I know it's hard to continue to talk about health inequities and structural racism. They've been there for generations, and we need to start somewhere and do something. And that's one reason why I am so thrilled to think about levers and have the collective thinking of the group participating in this discussion today. But even more, I know that the benefactor of Namor said, it's the duty of everyone to do what is within his power to alleviate human suffering. And he certainly invested in new ways of providing equal access to care, particularly for children. But I do believe ending inequality is possible. It may take time, the right words, the right investment, and the right leadership, but looking forward to the leaders who are joining the dialogue today. Thank you.
Thank you, Dr. Walker, and thank you again, Dr. Gordon.